Assalamu alaikum. In today's lecture, we are going to discuss about beta blockers. So, beta blockers, also known as beta-adrenergic blocking agents, are the medication that reduce blood pressure. This is the main or the simple definition of beta blockers. Subtypes: cardio-selective beta blockers. They include atenolol, metoprolol, and nebivolol. They act only on the heart. Okay. Cardiac non-selective beta blockers. They act hard on the lungs as well. They include propranolol, nadolol, and mixed alpha and beta antagonist like labetalol and carbidol. There is another category that is partial agonist like pindalol and S-butolol. They stimulate mildly when receptor is inactive and inhibit when receptor is active. Okay. Now let's discuss about mechanism of action. Beta blockers have following actions: antihypertensive, antiarrhythmics, myocardial ischemia, and infarction, congestive heart failure. So these four are the mechanism concerning beta blockers. So we will discuss one by one here. Okay. So if you didn't like the video yet and didn't subscribe my channel, kindly subscribe the channel for more videos. Okay, now we discuss about antihypertensive. Normally, the catecholamines epinephrine and norepinephrine binds to beta-1 receptor and increases the cardiac automaticity and cardiac conduction velocity. So beta-1 receptor also induce the renin release. This lead to increased blood pressure. Okay, so this is the normal functions of the beta receptors or beta. So when beta blockers bind to beta-1 receptor, they inhibit above mentioned effects. Like, therefore, chronotropic and inotropic effect on the heart undergoes inhibition, and as a result, heart rate slows down. Let me explain chronotropic effect. These are the factors that affect the rate at which cardiac muscle fibers contract. Okay. And inotropic factors are the factors that affect the amount of the force that cardiac fibers contract. So antagonism of beta-1 receptor results in reduction in the heart rate and stroke volume. I'm trying to make it simpler. The cardiac output is the product of heart rate and stroke volume. Okay, so cardiac output is reduced, which further leads to reduction in the blood pressure, because blood pressure is the product of cardiac output and systemic vascular resistance. I hope this makes sense. Now it makes it easy for you people to understand it. Beta-1 antagonism leads to reduction in the renin release, which in turn reduces production of angiotensin II, a hormone that induces vasoconstriction via aldosterone retention. Okay, now if we discuss it as class 2 antiarrhythmic drugs, beta blocker as tachycardia and antiarrhythmic drugs. They work by depression of SA node. It slows automaticity. Let me explain the normal physiology first. Beta-1 stimulation results in increase in the slow sodium current of action potential in phase 4 in the SA node. Okay. This results in faster rising and shorter phase 4. Faster rising and shorter phase 4, ultimately a shorter time to the next heartbeat, thus a faster heart rate. So when beta blockers given, they oppose this action, slowing down the SA pacemaker. Okay. Now let's explore depression of the AV node, prolong the refractory period. First we discuss about SA node, now we are discussing about AV node. A decrease in slow sodium current if it leaves the AV node in a refractory state longer. As a result, a long PR interval and a fast degree AV block. Prevention of depolarization. After depolarization, produce premature ventricular contraction, which can deteriorate into ventricular tachycardia or ventricular fibrillation. So in summary, beta blockers can be useful in tachycardia and arrhythmia. This anticardiac and antiarrhythmic effects achieved by depression of the SA node, which slows automaticity, depression of the AV node via prolongs the refractory period, and prevention and depolarization. I hope this makes sense. Now let's discuss about myocardial ischemia and infarction. Treating myocardial ischemia and infarction the goal is increase oxygen supply to myocardium and decreasing oxygen demand to myocardium. Okay, so beta blocker do this by slowing heart rate, that is equals to less work, that is equals to lower oxygen demand. So when there is slower heart rate, there is longer diastolic time and more time of myocardial perfusion, which occurs only during diastole. Okay, so low contractility, which leads to less work, which give you less oxygen demand. Ultimately the blood pressure will be lower because of the less work and because of the lower oxygen demand. I hope this makes sense and made it easy. Now let's discuss about another mechanism, that is congestive heart failure. It is a condition in which heart has a trouble pumping blood, in simple words. Okay? Patients with chronic heart failure have prolonged sympathetic stimulation and subsequent worsening of failing heart function. Beta blockers like selective non-selective counteract the effect of the prolonged sympathetic stimulation. So beta blocker causes improvement of left ventricular systolic and diastolic function and reversal modeling and heart rate control. Okay. Now let's discuss about pharmacokinetics. Short half-life and long half-life. The short half-life like 3 to 4 hours and the long half-life contains 10 to 20 hours. Example of the short half-life drugs are propranolol, metoprolol, and example of the long half-life drugs like nadolol and atenolol. Metoprolol is a lipid-soluble drug and therefore cross the blood-brain barrier. Okay. However, atenolol does not. The indications of beta blockers are hypertension, CHF, congestive heart failure, tachycardia, arrhythmia, angina, and myocardial infarction. Okay, as we are discussed already in the mechanism. The side effects include hypotension, bradycardia and heart block, impotence, fatigue, hypoglycemia, Raynaud phenomena, and congestive heart failure. The contraindications. In asthma, because asthmatic patients should not use non-selective beta blockers as blocking may lead to bronchoconstriction. Okay. Second degree heart block is also contraindicated. Second degree heart block can be converted to third degree heart block, resulting in very low heart rate. So it is contraindicated in second degree heart block. Bradycardia. Beta blockers could make the already slow heart rate, so slow cardiac output and blood pressure fall below levels that are required by the body for the adequate perfusion. Okay. Acute heart failure. This is contraindicated. Note that congestive heart failure, chronic congestive heart failure is indication for beta blocker, but an acute heart failure is contraindicated. Okay. So this is all about beta blockers. I hope this makes sense. Kindly like the video and subscribe my channel for more videos and support me through subscribing, sharing and like and comment your opinions. Thank you. Allah Hafiz.